There is a certain tension at the moment between academic psychology and clinical psychiatry. And that tension is not a tension that I feel. It's a tension between some sections of clinical psychiatry and clinical psychology and therapy. Because within the last 3 or 4 years perhaps, academic psychology, cognitive psychology, the work of Beth Loftus and others, has abundantly established that there is no reasonable scientific basis for claims of recovered memory of long duration and dating back to early childhood, which are so common. But psychiatrists and psychologists and some other therapists have been unwilling to recognize the scientific facts and face the issue of changing their interpretation of their material. Freud was one who did indeed change his interpretation of his material, as Paul has abundantly demonstrated. But when he did offer dubious invented memories, he did not suggest reporting the alleged perpetrators. He did not suggest confrontation. He did not suggest family breakup, and he did not suggest lawsuits. He worked as a sensible doctor, despite 1 or 2 flights of fantasy, which accompany the work of a creative mind. We have a different situation today in that there is resistance and unwillingness on the part of some therapists to recognize the phenomena to which I referred, the tremendous demonstrations from studies of memory about how unreliable these recovered memories so often are. And one of the reasons is, quite simply, that whatever repression means, psychiatrists, psychotherapists and others still want, to a considerable extent, to believe in it. And because we, on the whole, do not want to give up the notion of repression, so we dig our heels in, or some of us do, and offer reasons for continuing to reject the evidence which tells us that repression is a dangerous concept and a difficult one. I'm not saying that it should be dropped myself completely, but I will come to suggest that we need to revise what we mean by it. Other people, perhaps, have not yet realized that we can keep some of the ideas which are there without that we can keep some of the ideas which are there without while changing the topic. I don't want to throw out the baby with the bathwater, but some people think they've got to keep the bathwater. The idea of repression has been intellectually attractive. It has answered the search after meaning. It has been helpful to people practicing clinically, or at least they have thought it was helpful, and they thought it helped their patients. And it has been widely adopted and appreciated in literature and in the social sciences. Even if we were to say at the end that most of Freudian psychodynamics had to be abandoned, which I don't think is quite the case, we would still think, as W.H. Auden put it in his poem Epithalamion, which was essentially in honor of Freud, or part of it was much in honor of Freud, that he is today not only a man, but a whole climate of opinion. And there is great truth in that. But great climates of opinion, great theories don't always last. Of the perhaps 2 or 3 major theories of the last 150 years, those of Karl Marx have largely been rejected in most parts of the developed and semi-developed world. Those of Karl Popper have No, Karl Popper was not the theorist. It was not the great theorist. He was the clever theorist who fundamentally undermined Freudian ideas. And the theories of John Keynes, Maynard Keynes, are in economics are no longer very strong. Repression, which was the major part of Freudian theory, received its nemesis in the person of David Holmes in Kansas, quietly working away and steadily publishing the questioning information and literature which showed that it lacked scientific evidence. I said that that the idea of repression was clinically helpful, but it begins to look now as if it's a loose cannon on the deck. Maybe not just a loose cannon, maybe a loose atom bomb. And we have to wonder, still, even with all the things that I've said about why people want to keep it, or want to keep it in its unreconstructed form, why it goes on. Well, there is always, unfortunately, self-interest when a bad idea tends to persist. And there are payment systems, there is work, there are clinical practices which so far depend upon people believing that treatment of repressed ideas is an effective thing. The ideas, when they're practiced, also give... Thank you. A bit hard to disentangle oneself as well as repression. There is also a certain satisfaction in clinical practice. There is excitement even, and a sense of power which therapists get, and which we have to discipline. And there is a great deal of sensationalism and power about some of the over-imaginative theories of recovered memory. They have an attraction, therefore, to people who don't get enough satisfaction from their ordinary practice. And the eagerness and the enthusiasm that attend some of the demonstrations of the more improbable aspects of multiple personality disorder, the excitement over seeing or treating a multiple on the part of people who've swallowed this concept is easily recognizable, and if anybody doubted it, they could see how much attention it excites also among the general public, and how it's filled films, radio, newspapers, journals, popular books, and so on. Those things tend to keep the ideas of recovered memory going, and so does inertia, the simple failure of human beings to be prepared to organize or to do something against change. Besides the energy that powers these bad ideas, to which Paul has drawn attention, there's the inertia which tends to prevent their dissipation. There is some external support as well. It's a very odd type of support. It's not good feminist support, it is radical feminist support. And there are clearly extremists of a radical feminist nature who want to push a particular agenda on society, and the belief that males in particular, but some hapless females as well, have been abusing children serves their purpose. It's disgusting. Serious, but it exists. Now, it's not my purpose here to review that aspect, but it has to be recognized as a force which is contributing to the present distressing situation. Nothing, however, damages a bad idea, like pushing it to the limits. And the excesses of multiple personality disorder and of satanic ritual abuse have served to disenchant large numbers of professionals, even though their inertia may not have led them to protest very loudly. DSM-3R said that as many as 100 personalities might, or fragments of personality, might appear in a patient with multiple personality disorder. I haven't checked closely yet what DSM-4 says about that, but I think August, you did, and I believe that there's something there which lets that improbable concept remain. How anybody could imagine that a patient could manage 100 personalities, or even their fragments, keep them in order, remember them, know what each one had said to the other, or bring back out of the recesses of memory what one had forgotten and the next one had to present again to daylight. It's difficult to imagine. The same applies, of course, to satanic ritual abuse. Now, faced with the powerful data on memory and on suggestion, which are now available, and recognizing the damage done by extremism, many psychiatrists and others who don't wish to give up repression retreat to a sort of castle in which they say, I have to believe my patient, I can't go beyond that. And we've already seen one slide which pointed out the dangers of not being prepared to investigate the situation. Paul drew attention to that inimitably. Stephen Myrne is going to talk about something related to that, the therapist as detective or not as detective, as the case may be, before long. I think this afternoon. I want to just deal for a little while with the sorts of case, with some illustrations of how a therapist, or doctor rather, or psychologist will come to believe a patient or not believe a patient. When do we accept what the patient is saying and when don't we? When there's, for example, no immediate corroboration. This particular quotation comes from a television program where a member of the False Memory Syndrome Foundation was confronted with a psychiatrist who wanted to believe in repressed memories and who, I'm afraid, plugs the notion of sexual abuse in childhood being a common cause of adult problems. And she was challenged about this and said by recovered memories she thought perhaps something was meant called supposedly repressed memory. She was responding to a question about an inquiry about the false memory syndrome, and she said young women, educated, well-to-do, go to a therapist without any memories of having been abused. So she did get some idea of what we were talking about. And her reply was, my major concern as a psychiatrist is that this may be the beginnings of a wish to deny the sexual violence against women and children, men, boys and girls, that society really does not want to believe that violence exists, and this is the beginning of the denial process, which has been historical since 1860. Don't know why she chose 1860, but now the interviewer on this program pointed out the problems of things that did not happen being described as having happened. And she said, he pointed out that reputations and relationships had been ruined. There were reports of rituals and the consequent challenge to the credibility of psychiatric institutions. I've paraphrased him, he didn't speak quite like that. And the psychiatrist responded by saying that sexual violence against women and men, girls and boys, results in major psychological and physical complications. much of which we are still researching and beginning to know. And she was concerned that the entire field would be discredited in the public eye. So the unwillingness to look at some facts was defended by stating that we are finding out the facts. Now, essentially what she was saying was that she had to believe the patient. And I want to give a series of illustrations, some physical, some psychological, arising from my experience as a psychiatrist and as a physician over the years. And typically, if a patient comes to us and complains of a lump in the breast, we believe the patient. We expect to find the lump as a rule. We do examine the patient physically, or we make sure that somebody does. If a patient comes along and says he's got pain in the chest in front of the heart, we normally believe that the patient has a pain. We don't usually say that it's not there, so we tend to believe the patient. We think it might be due to several physical illnesses. I've listed a few of them. It might be indigestion, or it might be anxiety. And we go on to explore the possibilities and to try and reach a reasonable diagnosis. Here we are believing the patient, but seeking to make our own determination of why the patient's got that pain. If a patient comes in and says that, he gets a lot more skepticism. I pulled my back at work last year and it has gone on hurting ever since. A considerable part of my own practice has to do with chronic pain, and I generally find the patients are truthful. But there are always people around, and I have to be aware of this, who are skeptical of the reliability of reports of pain, particularly when compensation is attached to them. With chronic pain, however, there is often good corroborating reason to believe the patient, even if it's not found in the physical examination. Anyhow, we inquire. We can't take it for granted that the patient is being absolutely right. Now, I get palpitations and can't get my breath in church or synagogue. We believe the patient, and we also attach a psychological explanation. We never have a doubt about that one. There's a strong psychological complaint, an emotional one, but nobody complains about that if they don't have it, to my knowledge anyhow. We try and work out why it's there. I have to count everything in groups of 4. I can't get through the day because I spend my time counting and arranging everything. Whatever's on the table in front of me, I have to put out and check that there are 4 items, and then I have to get another 4 items. We accept the reality of the patient's statement. We believe the patient feels compelled to do what she or he describes, and we actually often prescribe medication for that. And remarkably, some of the medication has miraculous results. Here's another case where we prescribe medication. We may also prescribe behavioral treatment. It's essentially an obsessive-compulsive idea about having been fouled up by dog dirt. And again, the response to treatment is usually excellent. We do believe the patient, but we don't believe that the dog's shoes were actually fouled. Martians are subjecting me to radar. They have taken away my thoughts. Now, here we seriously accept that the patient is concerned. We don't for one moment believe that happened. We do think there's something to look into. That patient said that to me. The Royal Canadian Mounted Police have, or the CIA have put a transmitter inside my head to read my thoughts. This was said by a well-known psychiatrist in a program on Canadian television, Canadian Broadcasting Corporation. It's in a very interesting video called Mistaken Identities, produced in November 1993. The CIA, that patient said this to him. or words to that effect. The CIA abducted them, subjected them to sensory deprivation through, that should be goggles, not toggles, sorry, and implanted 5 alters. We don't believe the patient, but that doctor did. We also do not believe the additional statement that these alters were implanted in the patient so that the CIA could so that the individuals could carry more information for the CIA. This is quite typical of what I once saw doing my national service in the Royal Army Medical Corps in Britain. There was trouble at home and I missed the bus returning to camp. That's the last thing I remember until I woke up somewhere else. This soldier, of course, was absent without leave. Therefore, we may or may not believe the patient. We have an obligation, and I think a willingness, to treat patients with sympathy. We have an obligation to treat them with skill and with tact. We aren't obliged to challenge them inappropriately, and we aren't obliged to believe everything we're told either. Now, I think that should answer the suggestion, the implication that there is a difficult clinical situation which can only be handled by that should answer that suggestion. There's a difficult clinical situation which can only be handled by simply accepting at face value what is being said. Any trained professional has a greater responsibility than that. But that has become a main part of the unwillingness to look at the clinical situation and deny some of the obvious absurdities that have arisen, has also become attached to the insistence on retaining the idea of repression, which of course does deny what the patient is saying, or half the time. It's also become part of that defense of the existing position. Now, of course, the FMSF takes the view that real sexual abuse should be proscribed and punished. On the other hand, we do have important concerns, and we have concerns, obviously, some of which are very personal for members of the Foundation, completely personal. Some of us who've come to the Foundation by way of scientific studies have other additional concerns. And I have the concern that the utter nonsense which has been spouted about multiple personality disorder was making a laughingstock of my specialty. So I attempted to give reasons to get rid of it. They haven't worked yet to get rid of it, but I believe that the intellectual scientific standing of multiple personality disorder is now in tatters in most places. Why do things go on? Well, Richard Gardner has pointed out that mechanisms exist which encourage the detection of abuse and do not encourage very much the defense of those to whom the alleged shame is attached. And I think that's true as well. Obviously, the propagation of false cases causes harm rather than their identification. And so, professional self-interest remains immensely vigorous. Those other professionals, I believe like myself, who have just an ordinary concern for reasonable standards, feel bound to challenge some of those received ideas. And it's obvious for other reasons that this topic should be explored and scientifically evaluated, and justice and fairness demand a hearing for families that have been injured. What I've been talking about is standards of practice, which Paul beautifully defined earlier, and standards of evidence. And those standards of practice and evidence have been woefully lacking in psychiatry in the years in which these, or at least in this part of the field in which recovered memories have been advanced, and they've been equally lacking in the law courts. And they're a serious issue, both for psychiatry and for the law. I think I can conclude with that almost. I have to believe my patient in cases where allegations are made against other people. It's not unhelpful sometimes to believe the patient in looking at his or her past life, where it simply helps the patient without impinging on anyone else. But to say it in cases where allegations are made against other people demonstrates a lack of professional skill, which is so serious that prima facie it implies negligence. This is my last slide. I do not want to throw the baby out with the bathwater, as I said earlier. The ideas that have been attached to the word repression are not only the idea of something being pushed into the unconscious or into an unconscious part of the mind where it remains secluded and locked away. There is much else, there are other phenomena which we recognize are important in human relationships. The phenomenon of selective attention, of preferentially recognizing one thing and not noticing another. The issue of when we remember something because of motive. These are themes which may be handled behaviorally, or they may also be handled still by the traditional methods of introspective inquiry and discussion with a therapist. I think I could probably make a case, I don't do so today, to justify the statement that they are important. We don't want to get rid of them altogether, but we have to take a much more skeptical look at the original theory of repression. Thank you.